Hello, and welcome to this webinar on the CONSORT Statement, jointly organised by the EQUATOR Network and PAHO. My name is Shona Kirtley, and I'm the Research Information Specialist at the EQUATOR Network. Thank you all very much for attending the webinar today. It is wonderful to see that so many people have joined us. Today's webinar is the second in a series of webinars on good reporting of health research studies, organised by the EQUATOR Network and the Pan-American Health Organization, under their agreement of collaboration to help improve health research reporting in the Americas, through the use of reporting guidelines that promote greater accuracy and transparency. The EQUATOR Network is an international initiative seeking to improve the reliability and value of medical research literature by promoting transparent and accurate reporting of research studies. The EQUATOR website provides access to lots of resources relevant to research reporting, and the online library currently contains over 200 guidelines covering a wide range of study types and clinical areas. We are very grateful for all the help that we have received in organising the webinar today. In particular, we would like to thank PAHO, who are providing us with free access to the Blackboard Collaborate tool and with training and technical support. We also wish to thank Cochrane Canada for training support and for sharing their instructional materials with us. It is with great pleasure that I can now introduce Professor Doug Altman. Doug is Director of the Centre for Statistics and Medicine in Oxford and is also Senior Statistics Editor at the BMJ and Co-Editor-in-Chief of Trials. He is actively involved in leading the development of guidelines for reporting research, including CONSORT, STROBE, and PRISMA. And in 2006, he founded the EQUATOR Network. So Doug, I will now hand over to you for your presentation. Thank you very much.
Okay, thank you very much. I hope people can hear me. Good morning or good afternoon, depending where you are. So, as you know, I'm going to talk to you about the CONSORT Statement, which is a reporting guideline, guidance for randomised trials. So I'm going to start with a quotation from an editorial in the Journal of the National Cancer Institute a couple of years ago. Results from randomized controlled trials can have an immediate impact on patient care. Accurate and complete reporting is essential to determine whether trial design, conduct, and analyses are scientifically creditable. And in some sense, that summarizes where we are with reporting. It's terribly important for consumers of research reports to be able to understand exactly what was done. And CONSORT is a leading resource to help that happen. So if we consider research articles and what they're for, I believe that a scientific manuscript, as present as a journal article, should present sufficient data so that the reader can fully evaluate the information in that article and reach their own conclusions about the results to assess the study's reliability and its relevance to them. So readers have to have a clear understanding of exactly what was done, and that's true whether they're clinicians, other researchers, systematic reviewers, policymakers, or anyone else. The goal here, I think, quite clearly should be transparency, but also the article should not mislead. It should, I believe, have enough information provided to allow somebody else in principle to replicate that study. I think that's a good working definition of what we mean by transparency. And lastly, the results should be presented in a way that allows them to be included in future systematic reviews and meta-analyses. And I'll come back to those points in due course. There is, sadly, a considerable amount of evidence that many published articles don't adhere to those principles and omit vital information. There are, in fact, hundreds of reviews of that type, and they show that very often we cannot tell exactly how a piece of research was done. And although I'm going to focus today, of course, on randomized trials, these problems have been seen across the medical research literature. They aren't specific to randomized trials, they're not specific to studies of medicines, and they aren't specific to commercial research. So, moving on, here's another quotation which I think sums things up rather well. Whatever the outcome of a study, it is really hard for the average reader to interpret and verify the reliability of a poorly reported RCT, a randomized trial. In turn, this problem could result in changes in clinical practice that are based on false evidence, and that may harm patients. So we aren't just talking about fussy methodologists like myself, we're talking about important information that could actually have an impact on the way patients are treated and their long-term prognosis. So, what should be included in a report? Well, in terms of the methods, I believe that we should expect that all essential aspects of how the study was done should be reported. Many years ago, the International Committee of Medical Journal Editors produced this sentence which relates to statistics. It says, describe statistical methods with enough detail to enable a knowledgeable reader with access to the original data to verify the reported results. Here again you see the idea of replication. They don't, however, make similar statements about other aspects of studies, which I think they should. So we should really also expect that the intervention should be described with enough detail to enable somebody else to apply them. The outcome measures should be described in adequate detail as well, and so on. When it comes to the results, we should expect a journal article to present all the main findings in a useful and usable way, and that those findings would correspond to what was in the protocol, a pre-specified plan of how the study was going to be conducted. I focus here on methods and results. Of course, there are other elements in a journal article which I'll refer to in due course. So, what is poor reporting? Poor reporting, or perhaps more accurately bad reporting, is when, well, there are several types. There is the non-publication of a complete study. Obviously, this is something that doesn't reach publication, so it isn't part of today's consideration. What I'm focusing on mainly today is when in a published article key information is missing, it is incomplete, or it's ambiguous. And as I said, that relates to methods and to findings. It also extends to misleading interpretation, where the results are presented maybe and then interpreted with inappropriate emphasis on perhaps on minor findings rather than the main result. And that can be extended to the idea of selective reporting, where authors only present parts of the methods or those findings which they find most conducive to their preconceptions. And those obviously are not good practices. And lastly on this slide, we know that very often what's in a journal article doesn't actually agree with what was in the trial protocol, but there's no mention in the article of that difference, nor why such a difference took place. And that's something, when it's discovered, which is of real concern. Why is this study being reported in a different way? As I said, there is considerable evidence of poor reporting. I've seen many hundreds of published reviews of published reports of randomized controlled trials. They go across the whole spectrum of medicine. They're not in any particular specialty. They show that a high proportion of published articles simply do not contain the key information about the methods and results that we would expect as a reader. We cannot tell exactly how the trial was done, nor can we be sure exactly what was found, and that's unacceptable. So here's my first example. This is based on 2 reviews of the literature of randomized trial reports published first in 2000 in the left-hand column and secondly in 2006. Exactly the same information was sought. And the percentages shown are the percentage of reports in these samples of 500 or 600 each that did report what the primary outcome was, that there was a sample size calculation, 2 aspects of randomization, the method of random sequence generation and of allocation concealment, and lastly, whether the trial was blinded or not. Not whether this is whether it was or wasn't blinded, not so those percentages in the last row are simply whether it was made clear to the reader whether or not blinding was implemented, not what proportion were blinded. So those percentages show 2 things. They show firstly that there has been a clear improvement between 2000 and 2006, and we would hope in the subsequent 6 or 7 years that we've seen more improvement. But they also show that nearly all of those percentages remain very low. Even after the improvement, most of them are well below 50%, and that's obviously of great concern. To take a second example, this is a review of 262 reports of trials in oncology journals. Duff and colleagues looked to see how well the actual interventions were reported. They produced a list of 10 elements which they believed were essential, beginning with simple stuff like the drug name, but also the dose, the route, regimen, and so on. And only 1 article in 9, 11% of these articles, gave all the essential details which would be needed to repeat those therapies. And the quote at the bottom from their article makes that point clear, that randomized trials published in major oncology journals do not consistently report essential therapeutic details necessary for translation of the trial findings to clinical practice. Again, clearly that's not acceptable. And another example, this is a review of 49 trials of antiretroviral therapy of patients with HIV. Only 16, just about a third of the trials reported all adverse events. The other 2/3 reported only some adverse events. Sometimes they reported the most frequent adverse events, sometimes only those which were statistically significant, and sometimes they simply reported, quote, selected adverse events without any information about which other adverse events they might have recorded. And these authors said that these facts, i.e. these figures here that I've just shown you, obstruct our ability to choose heart as a type of treatment based on currently published data. Again, this is really not acceptable. And last in this sequence of examples is some evidence about selective reporting. This paper by Duan and colleagues was a review of studies which themselves had compared protocols with subsequent publications. It found that, or these studies which were reviewed found that the outcomes, the patient outcomes that were statistically significant were more likely to be fully reported in journal articles than outcomes that were not significant. And further, between 40 and 60% of publications had at least one primary outcome that was changed, newly introduced, or omitted compared to the protocol. About half, in other words. About half of the time, what's published does not correspond to the protocol for the primary outcome, and this is extremely worrying. The consequences of bad reporting are that assessing the reliability of published articles is seriously impeded. Clinicians reading this cannot judge whether to use a treatment, even if the trial shows that it's beneficial, and data often cannot be included in a systematic review. Therefore, as was suggested in my early quotes, there are serious consequences for clinical practice, for research, for policy making, and of course, ultimately, for patients. And the quote from The Lancet nearly 10 years ago now, saying the idea of a drug's use being based on the selective reporting of favourable research should be unimaginable. Changes are required at every level of the global healthcare infrastructure. So that comment based more on selective reporting than just bad reporting in terms of methods and so on. But all of these pieces of information point in the same direction, that research is simply not being reported adequately enough. And picking up the theme of systematic reviews, I won't read every bit here, but this is important. As I say at the top here, randomized trials have a second life where their results can be incorporated into future systematic review and contribute to much stronger evidence to underpin clinical practice. Here are 4 quotes from 4 systematic reviews, all complaining about the poor reporting in the primary papers they were looking at. The first one, poor reporting of trial methods. The second, poor reporting of the interventions. The third one, complaining that they couldn't use the data the way that the data had been presented in most of the trials. And the last one, poor reporting of duration of follow-up. So this isn't just a few examples. There's persistent and widespread evidence that reporting of randomized trials is inadequate very often, and this is of huge concern, bearing in mind that randomized trials are amongst the most important evidence that underpins the choice of clinical treatments for patients. So all of this leads to the idea that maybe if there were guidelines for reporting research, authors might do a better job, based on the idea that perhaps they don't really know how to present their results in the best way. So a reporting guideline is a minimum set of items required for a clear and transparent account of what was done and what was found in a research study. And those corresponds obviously to the methods and the results section. What was done in the methods, what was found in the results. And the guidelines reflect in particular those issues that might introduce bias into the research, things that you really want to know about how a study was done. Where possible, these guidelines are evidence-based, and also they reflect a consensus opinion, not just 1 or 2 people's views, but based on quite a thorough review of the literature and large numbers of participants to help come up with a sort of consensus view on what's the most important information to be reported. The benefits of using reporting guidelines, and of course today I'm talking only about randomized trials, but the principles apply to all research, that there will be improved accuracy, transparency, and indeed completeness of journal articles, of publications, that would make it much easier to appraise those reports for research quality and for their relevance. It would make it easier, as I said, also to include the data in systematic review, and it would improve people's ability to search the literature to find relevant studies. So what I show here is the early history, if you like, of reporting guidelines for randomized controlled trials. Before the 1990s, there were very few reporting guidelines, although there had been sporadic suggestions that such guidelines would be useful. Then, in 1994, 2 groups simultaneously published reporting recommendations. These were the SORT group and the Asilomar group, and without going into detail about those names, what happened was that clearly the idea was a good one, and 2 groups who had no overlap of membership met roughly at the same time and came to similar but somewhat different recommendations. There was then an editorial in JAMA written by Drummond Rennie, the deputy editor, who argued that really there was no room for 2 competing guidelines, and that what would be desirable was for those groups to get together and come to a unified set of recommendations. And that's what happened. In 1995, there was a meeting in Chicago. The name CONSORT was created. It stands for Consolidated Standards of Reporting Trials. And following that meeting in 1995, the first CONSORT statement was published in JAMA in 1996. And this is the title and the authorship of that paper, as I say, published in 1996. It included a checklist, which I show here, and you can see on the left it covers the title, abstract, introduction, but mainly the methods and results, and a little bit at the end about the discussion. And on the right, a whole series of pieces of information which the group believed was essential to be reported in a report for a randomized trial. I won't go into the detail of that because it's been superseded, as I'll describe. Also, these authors at that time recommended a flow diagram to show how participants went from the start, where they were registered or determined their eligibility, through randomization, treatment, follow-up, and completion of the trial and data analysis. And the idea was that each trial report should include a flow diagram like this, indicating not just the numbers going right through, but why people dropped out at different steps, where and why. So as I say, that was published in 1996. The rationale for the items on that checklist was the rationale I've been describing to you. It was necessary to have this information for the reader to evaluate the study. The items, as I also suggested, were evidence-based wherever possible. That means that there was evidence that the information being sought was necessary to assess reliability, or that there is evidence that these things were not being reported well. And the view was that this isn't a complete set, but a minimum set of essential items. And of course there will be other things that are important, and that will vary from trial to trial. After a few years, in a rapidly moving field, it became clear that this guidance needed to be updated. And following another meeting in 2001, a major revision was published. The checklist was revised quite considerably, and a few minor changes were made to the flow diagram. And there were two publications. A short paper, which is called the CONSORT Statement, was published, perhaps uniquely at that time, in 3 leading journals simultaneously. In addition, a very long explanatory paper was published in the Annals of Internal Medicine at the same time, I think 32 journal pages, explaining all the background and giving examples of good reporting. So this is, you may not be able to read that, but this is the CONSORT checklist in 2001. There are now 22 numbered items, and again, though, you can see that the bulk of the information requested relates to the methods and the results sections. And the right-hand column is intended to allow authors to indicate where they've addressed these points in their manuscript. The flow diagram has tied it up. It's slightly different, but it is essentially based on the earlier one, but now it's explicit that there are 4 stages here. At the top, enrollment, then allocation, follow-up, and analysis. But the principle is the same, to document the flow of the participants from the very start through to the analysis at the end. So I mentioned the explanation paper. We call it the explanation and elaboration manuscript, or E&E paper, and this was produced to help users of CONSORT understand why these things were important and what the rationale was for asking for these elements to be reported. So this paper gave examples of good reporting for each of the 22 items, gave a detailed explanation, and further it summarized the relevant empirical evidence about the way in which that was currently being reported. Well, that was in 2001. At that time, I think the goals were made rather more clear than perhaps previously. So the main objective of CONSORT is to facilitate critical appraisal and interpretation of RCTs by providing guidance to authors about how to improve the reporting of their trials. But a secondary objective was mentioned, and which was to encourage and provide incentives for researchers to conduct high-quality, unbiased, randomized trials, a sort of more diffuse but wide-ranging secondary objective. But clearly the primary objective is to improve reporting. In 2007 there was a meeting about revising it again, and that led to the 2010 revision of CONSORT. You'll see it took 3 years. It's a lot of work. This revision again led to a revised checklist. There was a short paper, this time published in 9 journals, and a revised and expanded explanatory paper which was published as well, and that's from the BMJ. 25 items now in the CONSORT checklist by 2010. This is the current version. Doesn't look, I don't think there's anything on that list that looks particularly unusual, but it's having it all laid out in a logical way that is meant to help people think how to structure their reporting, how to make sure they include all the important pieces of information. I'll point out that there are 3 separate elements to randomization, which of course is the most important part of a trial. It's the element that makes a randomized trial so much stronger methodologically than other research designs. So it is critically important that authors do tell us in some detail how they went about doing the randomizing. Here's a list of major changes. After one previous revision, it's interesting how much more was able to be changed in 2010. So firstly, 3 completely new items were added, reflecting current concerns. One about trial registration, asking for details of where the trial was registered, information also about where the protocol could be obtained, and about the funding for the trial. So these are, if you like, non-scientific issues, but increasingly seen as very important parts of information about the total trial. We added a new item to clarify the trial design. We added several sub-items, one of which is quoted here: any changes to the trial outcomes after the trial commenced, with reasons, and this links to the evidence I showed you earlier about frequent discrepancies between protocols and publications. Some items were made more specific. For example, we added a request for specification of how blinding was done, not just whether it was done, and if relevant, a description of the similarity of the interventions and the procedures. Conversely, we removed one sub-item about testing of blinding because we didn't feel there was good enough evidence that this was a reliable way to assess whether a trial genuinely had been blinded. On top of that, we simplified and clarified the wording throughout the checklist so that of these of the original 22 items, only 6 were completely unchanged between 2001 and 2010. And an important point, since we are very keen on transparency, is that all the changes which were made are documented in the paper that we published in 2010. So exact details of what was changed, and indeed why, are listed. Just to show you a couple of examples of the evolution of the wording as we strive for greater clarity. For patient outcomes, the original 1996 CONSORT asked for primary and secondary outcome measures. By 2001, we'd realized that might not be adequate and said clearly defined primary and secondary outcome measures. But clearly that didn't quite fit the bill either. So the current version is stronger still, completely defined, pre-specified primary and secondary outcome measures. And we added, including how and when they were assessed, recognizing that knowing what was measured is one thing, but knowing how it was done and when are often also extremely important. Likewise for interventions, rather simple. In 1996, the checklist asked for planned interventions and their timing. By 2001, this had become precise details of the interventions intended for each group and how and when they were actually administered. And the idea of replication is brought in 2010, the interventions for each group with sufficient details to allow replication, including how and when they were actually administered. And you can see here how accumulating evidence about reporting as it's practiced in the medical literature influences the way the CONSORT checklist evolves over time. And just to give you a single example, from the 2010 explanation and elaboration document, item 17B says, for binary outcomes, presentation of both absolute and relative effect sizes is recommended. And there's a lot of text explaining why it is recommended, but this table from a published trial is an example of very simple presentation which shows the results for each of two groups in a randomized trial, the risk ratio with the confidence interval, and also the risk difference with the confidence interval. And that information is very helpful if someone, for example, wishes to calculate a number needed to treat. But it shows that we can find examples of good reporting for all the items on the CONSORT checklist. It's quite hard, though, to find a trial report that reports all or even most of them well. And that's clearly then still a lot of room for improvement. So at the bottom on this slide is the reference of that paper, the E&E paper. There have been quite a lot of extensions to CONSORT. Extensions with guidelines on what should go in the abstract, guidance on how to report harms in particular as opposed to intended effects of treatments, a recent extension for reporting of patient-reported outcomes, and there are also extensions to cover specific trial designs, in particular cluster randomized trials and non-inferiority and equivalence trials. In addition, there have been quite a lot of what we call implementations of CONSORT, which take the CONSORT guidelines and consider how they might be applied for particular types of intervention or particular study types. The distinction between extension and implementation is perhaps not all that clear. So implementation articles have addressed herbal medicines, non-pharmacological treatments, which is a very wide area, pragmatic trials, and a very much more narrow area of acupuncture. To pick up the non-pharmacological treatments, this slide shows that we actually added some specific items about the interventions relevant for non-pharmacological treatments, recognizing that these are often complicated, they may have multiple components, and they might be tailored to individual participants. In 4B, questions the issue of whether interventions have been standardized, and if so, how, and 4C about adherence with the protocol by the care providers. These trials are much more complicated than trials of drugs, and that was the rationale for developing this extension. All of the papers I've just referred to can be mentioned on the CONSORT website. This is the home page of the CONSORT website, and the web address is at the bottom of this slide. And so, as I say, everything I've talked about, you can find much more detail on the website, including links to all the CONSORT publications. So here's the question. Does all this effort actually make an impact on the quality of reporting of trials? Well, let's have a look at some evidence. Firstly, uptake. CONSORT has very wide support from journals. On our website, you can find a list of over 600 journals which have supported CONSORT in some way. We use the term endorsed, but endorsement is a fairly loose description of support for CONSORT, the principles of it. We've also had support from major editorial groups, the Council of Science Editors, World Association of Medical Editors, and the International Committee of Medical Journal Editors, and for some peer review granting agencies such as the Canadian Institutes of Health Research. But the reality is that reporting guidelines have had rather limited impact, and I'll show some numbers in a minute. And this is probably because what we're talking about is passive dissemination based on publication only. We publish the guideline and hope that people will suddenly read it and do things a lot better. And in general, people don't change their behavior in such a simple way. And that means that the potential impact of CONSORT is really not being fully realized. This is part of the list of journals on the website of the journal endorsers, which I just mentioned. So one big impact of CONSORT has been the flow diagram. It's quite fun to go onto Google and look for images around CONSORT, and you get a display like this. There are loads and loads, hundreds of these, maybe thousands of these CONSORT flow diagrams out there in journals, and that's great. We conducted a review a couple of years ago of these flow diagrams to see how common they were and how well reported they were. And we found, as I said, they were very common indeed. The majority of articles these days have one, but elements of the flow diagram, especially the bottom part in terms of numbers of participants included in analyses, were often not very well reported. So yeah, a big impact in terms of adoption, but the quality of the flow diagrams remains less than optimal. Here's a review, summarize briefly a review of the reporting of adverse events. I mentioned those earlier, but this time in relation to CONSORT, noting that in this field of anti-epileptic drugs, reporting of adverse events is poor and has not improved since the publication of the CONSORT guidelines on the reporting of harms. As they say, these findings have serious implications as poor reporting precludes bias being detected and hinders adequate risk-benefit analysis. So in the reporting of harms, we have this and other studies showing that there's still a lot of room for improvement. This paper published by the CONSORT group recently is a review of studies that themselves had looked at whether reporting had improved since the publication of the CONSORT statement. So comparing either papers published before with papers published after CONSORT, or comparing papers published in journals that did or did not endorse CONSORT. Referring to endorsement, this quote points out that although the review suggests that endorsement may benefit the completeness of reporting, completeness remains suboptimal, very consistent with what we've seen in all the other studies. Journals are not sending a clear message about endorsement to authors submitting manuscripts for publication. Well, they're not, but they could. So here's from PLoS Medicine, the guidance they give to their authors. The part in bold: authors of trials must adhere to the CONSORT reporting guidelines appropriate to their trial design. Please check the CONSORT Statement website for information on the appropriate guidelines for specific trial types, and provide a copy of the trial protocol and a completed CONSORT checklist as supporting files, and they go on to say they will publish these. So this is a very strong statement, but PLoS Medicine is a big journal with resources, but some small journals can also behave in a similar way and try to strengthen the quality of the reports of trials that they publish. So here is from the journal Headache, their guidance, and they say, it is a mandatory requirement that a reporting checklist is submitted. We urge you, while completing this form, to consider amending your manuscript to ensure your article addresses all issues raised by the reporting checklist where appropriate. And they go on to suggest that it might greatly improve the manuscript and potentially enhance its chances for eventual publication. This passage is not specifically about CONSORT, but CONSORT is very much one of the guidelines which they are referring to, as is made clear. So, in conclusion, I believe that the findings of all randomized trials should be published. Trial reports should be complete and transparent and tell the reader what they need to know. We have a huge amount of evidence that many trial reports omit crucial information which greatly weakens their clinical value. And indeed, as we've seen, their usefulness for systematic reviewers as well. It follows clearly that peer reviewers and editors are failing to ensure that reports of trials are actually usable by readers, and they could do a lot more. Adherence to the CONSORT checklist and to the flow diagram would maximize the value of trial reports for other groups, for future systematic reviews, and ultimately for patients. And journals should institute stronger systems to ensure compliance with CONSORT. And I always tend to end with this red text. Good reporting is not an optional extra. It is an essential component of doing good research. So that's what I wanted to say to you. On this slide, you'll find the CONSORT Statement web address and also the web address for the EQUATOR Network, which will give you links not just to CONSORT, but as Shona said, to over 200 reporting guidelines. That's it. Thank you.
Thank you very much, Doug. That was really interesting. We've had quite a bit of activity on the chat function, and please do feel free to submit your questions through the chat function. We'll not be able to take any questions through audio, so if you do want to ask any questions, then please type them into the chat box, and we'll try to get through those now. We've got quite a few questions here. The first question I have is from Claudia, and she asks, is there a special CONSORT statement for herbal medicine?
Yes, there is. It was published, I can't tell you exactly where and when. Joël Gagné was the first author. You can certainly find details of that on either the CONSORT website or the EQUATOR website. The reason for having special recommendations for interventions like herbal interventions is that they're not standard manufactured products, and therefore quite a lot of information is needed to impart to the reader to understand exactly what the intervention was. But yes, there is such guidance.
Okay, thank you. I have another question here from Sim, who asks, was CONSORT published in languages other than English?
Yes, that's another question which I could have answered in my slides, but I'll answer it now. Yes, I can't give you the number, but I think CONSORT has been translated into numerous languages. Certainly the checklist has been translated into very many languages, but I think also the papers have been published in Chinese, Spanish, German, I think, and several other languages. Again, if you go to the CONSORT website, you should find lists of translations, again, with links.
Okay, thank you. I have another question here from Caesar from Peru, and he asks about the CONSORT methodology and can it be used for evaluation and for RCTs applied to complementary and alternative medicine?
Okay, well that's two questions. I think that the second one is similar to the question for herbal medicines. Yeah, the CONSORT is written in a generic way, so it would apply to any randomized trial of a healthcare intervention, and indeed, by and large, to any randomized trial. But obviously there may be specific aspects of particular interventions that might need to be thought about, which is why there is a guideline for acupuncture, for example. In terms of using CONSORT for appraising reports, it is often done. The difficulty is that there is quite an important distinction between the quality of reporting of a trial and the quality of the conduct of that trial. And it's entirely possible that you get very good reporting and very bad methods. It is not therefore wise to assume that a well-reported trial is an unbiased and well-conducted trial. There are other checklists around for assessing the methodological quality of trials. For example, the Cochrane collaboration has a risk of bias assessment tool which is explicitly designed, as its name indicates, at judging the extent to which the results might have been influenced by bias through the way the study was conducted. So I wouldn't encourage using CONSORT in that way. Likewise, I think the CONSORT checklist can be very useful to people who are designing a new trial, but a better guidance for those people is the recently published SPIRIT statement, which is a set of guidelines on writing a clinical trial protocol. And I know at least one person asked a question about SPIRIT. But SPIRIT is quite different from CONSORT. It's about the protocol, and CONSORT is about the journal article. But if you compare the checklists, you'll see that there are quite a lot of elements which are either identical or very similar indeed, and it would be surprising if that were not the case.
Okay, thank you. I have another question here from Louis, who's asking or saying that there's the implementation of using the CONSORT guideline is a challenge due to journal word counts. And he wonders how many words are needed to report following all the CONSORT items, and have you ever managed to calculate that or tried to calculate it?
Well, that's a fine question. I have several things I can say there. Firstly, if existing reports are missing key information and they need to add it, then in essence it is bound to make the paper longer. But I and many others feel that a lot of words are often wasted, for example in the results section, by repeating a lot of information that's already in the tables, and in the discussion section with a rather extensive speculation about what it might all mean. And I think there is space saving that could be achieved in those areas. But whereas this issue of word limits was a real problem 5, certainly 10 years ago, I think it's a non-problem now, because really virtually all journals allow web appendix, electronic only material. So if there isn't room in the main article, it's entirely reasonable to have a supplement that's online that gives full information. And indeed, I already mentioned PLoS Medicine will publish the whole protocol as a web appendix. Other journals will do that as well. So yeah, it was a problem. It's not really a problem now.
Okay, thank you. The next question comes from Christoph, and he was wondering, can you speculate that using CONSORT we can or should reject some RCT results from meta-analysis because of poor reporting, and is that enough justification to do so?
This is difficult. It links to what I was saying about the Cochrane collaboration's risk of bias tool. If you don't know, for example, if you don't know how the trial was randomized or whether it was blinded or not, you have to have some raised suspicion that things may not have been done very well. It's of course entirely possible, and there is some evidence that many trials are done well but reported badly. So to assume that if it's reported badly, it's unsound is not very good idea. On the other hand, to assume the opposite, that well, it doesn't matter about reporting, we'll assume it was done well, that's not very wise either. And so there's a real dilemma for people who are praising evidence. And basically that is really the whole rationale for CONSORT. You shouldn't be in that situation. If all trial reports were adequately reported as laid out in CONSORT in all journals, then you would be able to appraise a study far more quickly, far more reliably, and we just need to ensure that peer reviewers and editors come more on board and understand why this is so important. But ultimately, we need researchers to buy into CONSORT and recognize their responsibility to the participants in the trials, to the people who funded those trials, to get the maximum value for the future.
Okay, thank you. The next question comes from Hend, and he wonders, should Spirit 2013 supersede the CONSORT for RCTs guideline?
Well, the simple answer is no, because as I said, it's a guideline for how to plan a trial, how to write a clinical trial protocol. What I would say, though, is that if you've written your protocol following Spirit, it would make adherence to CONSORT easier when you come to write up the paper, because all that material will be in the protocol, and it takes you a long way. If you have a really good protocol, it takes you a long way towards writing a really good journal article. But it's CONSORT that really is the one to look at when writing the article.
Okay, thank you. The next question comes from Steve, and he asks, do you think there is value in requiring a manuscript to be structured content to ensure compliance with guidelines?
I really like that question because I absolutely do think so. I think one of the problems, one of the reasons why a lot of information is missing is that it's hard to tell that it's missing, because the basic structure of journal articles is narrative and not structure. So I do personally favor much more structure. We've seen with the flow diagram that the people have bought in a big way to that very structured way of describing how participants flow through the trial from beginning to end. We also see in randomized trial reports, Table 1 is almost always a structured display of the baseline characteristics in each group. I would favor extending these ideas and having more structure. The most simple way to do that is to have more headings, subheadings within the methods and results sections. And some journals are better than others at that. But if you have a section on randomization, a section on blinding, and so on, it's much easier to judge whether the information provided is adequate or not adequate. And certainly, you can't miss it out altogether if you have to have a heading.
Okay, thank you. The next question comes from Jose, and he asks, can you speak about patient-reported outcomes?
Well, can I speak about it? Yes, I can. I'm not going to say a great deal about it, but patient-reported outcomes do raise certain methodological issues which are different from simpler outcomes. One would certainly, for example, would like to have information about the exact nature of the, if they're using a scale to assess some outcome, one would like information about the derivation of that and maybe the repeatability and so forth. The CONSORT extension for patient-reported outcomes was published recently in JAMA. Melanie Calvert is the first author, and if that's your area of interest, I suggest you consult that article, which goes into these issues quite thoroughly.
Okay, thank you. And I think we've just got time for one last question. And this is from Louis, who asks, he's talking about, thank you for showing what PLoS and other leading journals are doing to implement recommendations. And he asks, does EQUATOR or CONSORT offer a standard text similar to what you showed that journals can cut and paste into their recommendations? And he goes on to say, sometimes it seems like those implementing the guidelines get stuck on things such as this working, and I wonder if a generic phrase would help.
Yeah, our reviews of journals' instructions to authors, a few years old now, did show that there was far more information about process and very little about content. In terms of policy, however, yes, on the EQUATOR Network's website, there is a section which is targeted at journals, and you will find some guidance in there for how journals can give to word the information for their authors about what they expect from authors in relation to reporting guidelines. Thanks for that question.
Okay, thank you. I'm really sorry, we still have quite a lot of questions in the chat, but I'm afraid we are out of time now. Thank you all very much indeed for participating in the webinar this afternoon. We hope that you found it interesting. The PowerPoint presentation and the recording will both be posted on the EQUATOR website, and we'll send all participants the URLs for that in an email. So thank you very much indeed.